Hello, I am Dr. William McGuire. I'm actually a medical oncologist who, for the last 20 plus years, have limited my practice to the treatment of female pelvic cancer and specifically ovarian cancer. And I wanted to spend a few moments today talking to you about a very, very common problem in patients with ovarian cancer, which is what do I need to do if my CA125 is rising? What is CA125 and what value does it have? Well, first thing for people to understand is that 10% of patients do not even have ovarian cancer that produces CA125, so it is of no value. The two most common tumor types, there are about 5 different types of ovarian cancer, but the two most common tumor types that may not produce CA125 is mucinous carcinoma of the ovary and clear cell carcinoma of the ovary. So if your CA125 is normal, having the CA125 checked every month is really a waste of getting stuck in the blood drawn because it really doesn't tell you or the doctor much of anything. There are about 20% of patients that have very low levels of CA125, and so trends or changes in the CA125 are often misleading, and you may see a small rise in the CA125 and be terrified that this means the ovarian cancer is coming back when it really isn't. What CA125 is a glycoprotein. It's actually produced by the cancer cell and excreted into the bloodstream and can be assayed. Not every cell in a tumor mass produces CA125, so we know that some cells produce it and some cells do not. And one point that I would like to make is that I've had patients say, well, if my CA125 went from 100 to 200, does that mean that my tumor is doubled in size? And the very clear answer to that is no. There is not a direct correlation between the absolute level of CA125 and the absolute number or size of recurrent ovarian cancer. Nevertheless, it may be useful in some patients for determining the status of their disease. Is CA125 good for screening? Now, this is probably the wrong audience to be talking to, but if you've been diagnosed with ovarian cancer, many of you have daughters, and your question is my daughter at risk for developing ovarian cancer, and should she start having screening tests to find out, to try to pick up her ovarian cancer early? It is currently not recommended for the general population. It is only recommended for patients who have a positive BRCA mutation or a strong family history. And if you haven't had the BRCA mutation checked, you should have. You should ask your physician to have that done, because current recommendation is that any patient with ovarian cancer, whether they have a strong family history or don't have a strong family history, should have the BRCA mutation checked, not only for the sake of their family members, because if they have the mutation, there's a 50-50 chance that each of their children could inherit that mutation. But also, as we're learning more about this, we have learned that patients that have the BRCA mutation actually have a type of ovarian cancer that is more sensitive to chemotherapy than those patients that don't have the BRCA mutation. So it's important, if you haven't had that done, that you ask your physician to send you to a genetics counselor and have that test done. But short of having a known mutation or a very strong family history, and that's a family history not only of ovarian cancer but of breast cancer, those tumors tend to be seen in the same family, this is not a good test for screening. So if you have family members that are asking, well, my mom's got ovarian cancer, should I start having CA125 screening? And you don't have a strong family history and you don't have a BRCA mutation, the answer is categorically no. it is not a good screening test for a number of reasons. First and foremost is 50% of patients with early ovarian cancer, that is with stage 1, the most surgically curable stage of ovarian cancer, have completely normal CA125. So if you just use CA125 to screen, you are going to miss half of the patients at the time that they have stage 1 or early and highly curable ovarian cancer. Elevated values over 65 are predictive in some patients of ovarian cancer, but not all. And anytime that there is a concern because of a high or a rising CA125 in terms of screening, that should be confirmed by a transvaginal ultrasound. CA125 is done by 2 different assays, and one of those, the upper limit of normal is 21, and the other, the upper limit of normal is 35. And some patients may have their CA125 checked and assayed in 2 different labs. And the first lab, the upper limit of normal is 21. The second time they have it done, the upper limit is 35. And their CA125 went from 20 to 30, and they become frantic that they have recurrent ovarian cancer when it's really not that at all. It's simply a different assay. Most suggestive of an ovarian cancer, either a new ovarian cancer in a previously unaffected patient, or in a patient with known previous and previously treated ovarian cancer that the ovarian cancer may be coming back, is a steady rise in the CA125 levels over time. We do see patients that have abnormal CA125 values, 50 for example, but each month it's 50, the next month it's 51, the next month it's 49, the next month it's 52. I'm actually less concerned about that patient than I am a patient who has a value of 6, and the next month 11, and the next month 17, all of those within normal limits, but each month the value is going up. So it's actually a change in CA125 over time that is more important than a single value of CA125. Is there any value to following the CA125 during treatment? And the quick answer is yes, to some extent. The quicker the CA125 falls during treatment is suggestive of a better outcome. And there are a number of studies that show that if your CA125 is elevated prior to the start of chemotherapy, and that CA125 goes into the normal range very quickly, particularly if it goes into a normal range after 1 or only 2 cycles of chemotherapy, those patients typically have better outcomes, longer survival, higher cure rates than in patients where that CA125 value falls very slowly. And in the patient where the CA125 does not ever reach a normal level during the initial chemotherapy, virtually all those patients will develop recurrent ovarian cancer, and many of them will develop that recurrent ovarian cancer fairly soon after completing the primary chemotherapy. Failure of an elevated CA125 then is really indicative of treatment failure, and should alert you to the fact that you may need to change chemotherapy sooner rather than later. Increases in CA125 following treatment may be indicative of a recurrence, and I've underlined the word may because it does not necessarily mean that the tumor is coming back just because the CA125 has gone up a little bit. Again, it's trends that are more important, and so if 1 month your level is 4 and the next month it's 8, but the next month it's 6, that does not necessarily mean that you are going to develop recurrent ovarian cancer, although values that go up and exceed 100 are usually very, very highly predictive of recurrent ovarian cancer. Rises in the CA125 often occur prior to the onset of symptoms, and often even rise prior to any abnormalities in a CT scan or even a PET scan in a patient who is asymptomatic. this is what we call lead time bias, and what has been learned over the years, over the 40 years that we've been looking at CA125, is that on average, from the first rise in CA125, significant rise in CA125, to the development of recurrent ovarian cancer is about 3.5 to 4 months. But there are some patients that have rises in CA125 and don't develop recurrent ovarian cancer for a year or sometimes even 2 years. So just a rise in the CA125 and even a significant rise probably heralds the onset of recurrent ovarian cancer. Typically, a diagnosis will be made within about 3 to 4 months, but that is not true of every patient. Is there any value to treatment of isolated CA125 elevation without symptoms or with some abnormal CT scan? And a large study from Great Britain, I think, categorically says no, that there is not really any value to treating what we call biochemical recurrence, which is elevation of the CA125, and we're talking significant elevations now, elevations in excess of 100, which probably means that the ovarian cancer is going to come back. But as I've already pointed out, even though on average this is only 3 to 4 months, it may be a year and a half, even on the outside 2 years before that tumor rears its ugly head again. And that study from Great Britain determined that on average, even though it's 100 days on average before you see a change in the CT scan or the development of symptoms, it may be much longer than that. In that study, they treated patients there were some patients who were treated on the basis of a rise in the CA125, another group of patients who were not treated on the basis of a rise in CA125 and were only treated when they developed either symptoms of recurrent disease or were found to have new findings on a CT scan. And what was interesting in that study is that the patients that were treated on the basis of a rise in the CA125 did not have any longer survival than the patients who had delay of that treatment until there was either some symptom of recurrent ovarian cancer or a finding of a new mass on a CT scan. And furthermore, the quality of life of that former group, the group who were treated on the basis of the CA125, was actually worse than the quality of life of the patients who were treated only at the time that they developed a symptomatic or a scan finding of recurrence. Largely because the patients that were treated on the basis of CA125 were constantly worrying from month to month, what is my CA125 value, whereas the group that were not treated on the basis of CA125 but on the basis of symptoms were not even told what their CA125 values were. So over the 20 years that I've been in practice, there have been times when I've even told patients, let's not draw CA125s, but I have learned that if I don't draw it, they're going to go get the laboratory value drawn someplace else and then come back to my office when the value goes up and say, okay, Dr. McGuire, what am I supposed to do about this? And I'm going to tell them what I've just told you here on the slide. If your CT scan is normal and you have no symptoms whatsoever of recurrent ovarian cancer, current thought is that it is not advantageous to initiate treatment solely on the basis of that CA125 elevation. It's much better for you in the long run to wait until there is something seen on a CAT scan or you come in with some symptom of recurrent ovarian cancer such as nausea, bloating after eating, constipation, bladder symptoms, the whole host of symptoms that may herald the onset of recurrent ovarian cancer. How about other tumor markers? Well, there are many tumor markers that have been purported to assist in helping pick up early ovarian cancer as a screening tool or in following patients that have ovarian cancer in terms of how they're doing. Some of these are HE4, CEA, LASA, but so far none of those have really added anything to just the CA125 in terms of screening or in following treatment, except for the occasional patient who has a normal CA125, but one of the other markers is elevated. So there are a few patients that may have a normal CA125, but an elevated HE4, and if that's the case, then it's perfectly appropriate to follow the HE4 and not to follow the CA125 in terms of how the patient is doing with their ovarian cancer. Some frequent misconceptions about CA125. Doubling of the CA125 means my tumor is doubled in size. I've already mentioned this, but the clear answer is no. A halving of the CA125 means my tumor is half the size. For the same reason that the first bullet point, the answer is no, the answer here is no as well. Although as a general rule, if the a normal CA125 assures me my tumor is in remission, that's not true either. There are some patients who have tumors that do not produce CA125. 20% of patients have types of ovarian cancer that do not produce CA125, and so a normal CA125 in no way, shape, or form means that the tumor is in remission. And even patients that have ovarian cancer that produces CA125, about 10 to 15% of those patients develop recurrent disease without an elevation of the CA125. A rise in the CA125 means my tumor has returned. We've already discussed this previously, but a small rise in the CA125 does not necessarily mean the tumor has recurred. And to treat that small rise in CA125 may actually be treating you with drugs that have toxicity when there is never going to be a recurrence because you are already cured of your ovarian cancer. So again, I would say that it's more important to wait until there is either evidence on a CT scan or a PET scan of recurrence, or evidence on the basis of new symptoms that suggest recurrence before initiating chemotherapy. Be that as it may, however, in terms of just following CA125, and this is a very broad rules, if the CA125 is going up, it obviously is a concern to the patient, it is of concern to the physician, and it means that the physician is probably going to look more carefully for the possibility of recurrent disease. A CA125 that is going down in a patient who is undergoing therapy generally is good, not 100% of the time, but as a general rule, if the CA125 is dropping during treatment, it is usually an indication that the treatment is being effective and doing what the treatment is designed to do. So that's a very quick overview of CA125. It is a very, very common problem that patients that have been treated for ovarian cancer have. Please do not assume that small changes in the CA125 necessarily mean the tumor is coming back, and please don't become what I call a CA125 addict, which is the patient that calls the office usually 12 hours after the CA125 has been drawn and say, what is my value? And the value is changed by 1 or 2, and you become frantic and assume that that means the ovarian cancer has come back. You're going to spend too much of your time worrying about something that you oftentimes just don't need to worry about. So CA125 has some use, but has unfortunately, I think, been overplayed both by physicians and by patients in terms of its overall meaning in the management of this disease. Thank you.